I'm excited to have my friend Dr. Scott Watson here with us. It's your first time actually in our space. That's pretty cool. But just an opportunity for us to get a surgeon's perspective on some of the more common questions that we get from patients, particularly when it comes to knee and hip injuries, knee and hip surgeries. That's one of the things that Dr. Watson is known for around here. And so glad to have him. Thanks for taking some time to join us.
Yeah, thanks for having me. Happy to be here.
So I want to start with some hip stuff because I know there's fewer of you guys that do hip arthroscopy around here. So I want to start with that. So for me, questions that we get for folks that maybe either aren't responding to traditional PT methods or are just kind of in that discovery stage of understanding what do they need for their hip. One of the most common questions that we get is, do I need a hip replacement, or is there some other procedure that we can do to try to save or spare the hip that I have? So what is some of your thoughts and decision-making that goes into that?
Yeah, so the number one cause of young athletic hip pain is femoroacetabular impingement, or FAI, which is basically a mismatch of the ball and socket joint.
Yep.
And that almost always leads to cartilage damage, which would be a labrum tear. The vast majority of people under the age of 40, that's going to be their diagnosis if they're having intra-articular type hip pain. Certainly as we age, arthritis becomes more of a consideration. The leading cause of young hip arthritis is untreated femoroacetabular impingement. And so that's usually a cause. How do we make the decision of treating that versus a hip replacement? Basically, it's based on imaging, which would start with plain x-rays in the office and an evaluation, and then sometimes advanced imaging with an MRI.
Okay. So you mentioned the femoroacetabular impingement piece, which is something that we encounter clinically a lot, particularly in young to middle-aged athletes. So then let's focus specifically on that, and let's say this is not an arthritic hip. This is specifically just FAI. What are some of the signs that you see either clinically on imaging that says this is a person that's going to need surgical intervention versus somebody that merits a trial of some PT self-management conservative care?
Yeah, I think honestly that's a big part of it is when they failed some of the conservative management. We have pretty good studies to show us from the NFL Combine and some other studies to show us that there's a high rate of asymptomatic FAI on radiographs. And so just because you have an x-ray that shows you have FAI doesn't necessarily mean you need hip surgery. But when you've tried to manage it with good physical therapy, treatment of the extra-articular symptoms, as we call it, and you continue to have pain, and then on imaging, if you have labral tear or signs and symptoms of a labral tear, then that's usually where surgery becomes part of the discussion.
So let's say now that this person is somebody who we feel like is a good candidate for surgery and needs that. Questions that we often get when it comes to that is, it's just one of those arthroscopic procedures. It's really minor, very little downtime, quick recovery, right? Yeah. And I have found in my experience, and I know that you have as well, the hip's a little different with that. So talk to me a little bit about what you say to patients when they're asking about what are their expectations for downtime and recovery, even though this is just, quote, an arthroscopic surgery.
Yeah, I think that's one of the challenges, right, is that surgery can be done through two tiny little poke holes. It's camera surgery, and the perception would be that it's a minor surgery, but there's a lot of work going on in there. In fact, I often tell the patients that are on the verge of total hip versus hip arthroscopy, the total hip, ironically, is a quicker recovery because you can weight bear on it immediately.
Absolutely.
You can range it immediately, and your metal and plastic heals faster than suture and your tissue. Yep. And so, it is a prolonged recovery. I tell people it's a 4 to 6 month process, but it's a beneficial process if you get through that because you maintain your anatomy and can get back to a more athletic lifestyle.
Right. I find both myself and then now having a practice where I have therapists of varying experience levels when it comes to rehabilitating hip arthroscopy patients. I find again, patients maybe have some expectations that the rehab's going to be easy. I think some young therapists come in with expectations that this is a really straightforward rehab process too. And I have certainly found that is not the case. So I can certainly comment on this some, but I just want to hear from your perspective. Where do you see the rehab process going wrong or maybe just not helping when it comes to somebody that maybe hasn't seen something like that before?
Yeah, I think it's a good point. And to your point, hip arthroscopy is more what I call tricky than or hip rehab, is more tricky than just a simple knee scope with a meniscectomy or even a rotator cuff. That's you see 10 of those for every one hip you may see.
That's right.
And so what I usually tell the patients is there's only a few surgeons that do this surgery in the city, and so there's not that many therapists that are seeing high volumes of this, and I do think that the people that are seeing it more often are more experienced at it, are more in tune to picking up the nuances of it, which it is. There are a lot of nuances: the hip flexor, the glutes, the other back pain that relates to that, SI joint dysfunction. It's a very complex thing, and I learned that in training, but then also with my personal experience that it's a very, there are a lot of other causes of hip pain, and we can do the same hip surgery, and a physical therapist can go down the wrong path, and the patient will come back and say they're not doing better, they're having a lot of pain.
Right.
Or we can do the same surgery and they go to someone that's very experienced in this, and they come back and say I have no pain.
Right.
And so I think it's a very complicated joint, which makes it fun to take care of, but also makes it challenging to take care of.
For sure. So you jumped right into the next thing I was going to ask. You are uniquely experienced and qualified in this surgery, given that you've experienced it yourself too.
Yes. Yeah.
So talk to me both from the surgery and the rehab standpoint. Like, what did you learn going through that process yourself that you couldn't have learned just being a surgeon?
Yeah, I think the biggest thing I learned is all the different sources of hip pain.
Okay.
We even in our modern medicine, we're trained on the pathology and to fix that. So I can repair the labrum all day long and treat the impingement. But if the mechanics of the hip aren't functioning well, it's going to continue to hurt.
Right.
And I think there's so many other causes of hip popping, snapping, referred hip pain, deep-seated groin pain when you sit for a long period of time, change of direction pain, and in a lot of different ways to address that through some good exercises, strengthening, and then sometimes even manual releases or dry needling done by the physical therapist. And so I think that's what's helped me the most as a patient on the patient and doctor side of this is that there's a lot of different sources of pain.
Yep.
And oftentimes people come to my office and say, my hip's catching, I have a labrum tear, it needs to be fixed. And that's usually the least likely cause of an actual catching symptom for a patient is the actual labrum.
Right, exactly. Okay. So you mentioned the importance of the rehab side. Talk to me about, and this can be hip specific or this could just be in general to post-surgical rehab, but for you, what does the ideal communication and relationship look like between therapist and surgeon as they're walking somebody through that rehab process?
I think it's got to be closely united. You got to be on the same page. I think communication's key. Patients expect that, deserve that. And so I can't be telling them one thing and the therapist telling them another thing.
Right.
We got to be on the same page, and we have to understand what the goal is and what the progression is and be united in that as well. And so, I think an ideal relationship is that, a relationship where there's back and forth communication. And, I've the other thing I've learned through my own personal experience is that you guys have a lot of knowledge that orthopedic surgeons don't necessarily have, and vice versa, right? We have each other's skill sets for a reason. And so
I think that's why stuff like this is so helpful. We get to play on one another's home fields a little bit every now and then. Like the value that I've gotten from being able to spend time in an operating room with folks like yourself or others just gives me a totally different perspective, just like being able to step into the rehab world sometimes I think is really helpful too.
Absolutely.
So what are surgeons obviously have to be selective in who they operate on, but even if you are choosing to do particularly hip surgery in this case, what are some of the factors that you've noticed that have a strong correlation to surgical outcomes in terms of whether it's patient demographics, activity levels, things that are modifiable or non-modifiable?
Sure. So the classic hip arthroscopy patient would be a young athletic male or female, meaning probably under the age of 25, that has a clear visible deformity on imaging, meaning impingement, with a labral tear that's visible on MRI, that has classic, what we call C sign, deep-seated groin pain, that is reproducible on exam. And then if you went one step further, some surgeons would say if they had a positive response to an intra-articular injection, meaning that it addressed all their pain, which confirms that the joint is the source of pain.
Okay.
And often we'll discuss that with patients. So if we start there, that's the baseline, is maybe a 16-year-old soccer player that's got a big impingement that has a labral tear on MRI, and we gave him an injection and he felt great for however long that may be. And then we go forward from there. Well, not everybody's going to fit that. I don't fit that. A lot of people don't fit that. But then we just have to be aware of other complicating factors, whether it be muscle tone that needs to be addressed or some arthritic changes that may or may not be treatable with hip surgery, or physical therapy that needs to be handled beforehand.
Yep.
So yeah.
What obviously you're a surgeon, so you do surgery, but what other treatment modalities are you finding success with individuals that don't involve surgery or PT, whether it might be biologics or stem cell or all the other things that people are Googling and doing research on, doing everything they can to avoid having a hip surgery? What of those things actually have some evidence behind them?
Sure. Yeah. I think the orthobiologics are, when we say that term, that the common would be PRP, platelet-rich plasma.
Right.
There's also bone marrow aspirate concentrate, which we'll use sometimes in the operating room, and then there's stem cells, and all these are regenerative type techniques. I do think they have a role, and we've seen it change things a lot. Like there's certainly a lot of patients that do better with those treatments if you have a clear indication for that. That treatment is very unlikely to fix a mechanical issue inside your body, whether it be a displaced meniscus tear or a retracted rotator cuff tear or a labral tear or an impingement. It's unlikely to fix those things. It may alleviate some of the symptoms, and we are constantly gathering more evidence on what that looks like going forward. I do think there's a role for that, but obviously there's also a role for surgery is the challenge.
For sure.
Everything is not treated with one or the other. I think a combination approach is the best.
Yeah.
But I certainly think we use that in our practice on a regular basis. And I think it certainly has a role for the correct indication.
And are you augmenting any of your surgical techniques with any of those, like concurrently?
Yeah, I am. In certain cases where we feel like that a boost of orthobiologics would help, some tendon repairs, certain cases where there may be a pre-arthritic joint where there's started the arthritic process, or something that the tissue quality just may not seem great, and we need to give it every help that it can have to do that. Back to the typical patient, the outcomes of a young, healthy person with a labrum tear with surgical fixation are very, very good.
Yep.
And so I don't see the need to just routinely put in something that would be a cash-based service like orthobiologics when the outcomes are really good.
Yeah.
Contrast that to a meniscus repair where sometimes the outcomes are not as good. If we've got a high-risk tear that I'm worried about healing, then I do recommend to patients that we augment that with orthobiologics injections.
Right. We're already in there. Might as well do everything we can to give it the best chance to be successful, right?
Yep.
So talk to me about, obviously, surgery in and of itself can be a very scary thing for some people, right? And so maybe they're walking around with that. I mean, yeah, I do feel a twinge of hip pain whenever I get into a deep squat or I ride on my bike or whatever it is. But honestly, it might not be worth the risk of having some big scary surgery. What's your advice to that person that's like, they're suffering, they're having hip pain, they're just kind of biting the bullet, so to speak, from the standpoint of they don't want to risk what else comes with surgery and the risk of a bad outcome and all of that. What's your perspective to that person?
Sure. Yeah. I think I would say that FAI and labral tears is probably one of the most predictable treatments we have, and often that can be non-surgical. And for us in our practice, surgery is a last resort.
Right.
When there's nothing else we can do to address the pain, then that's what we use to address that.
Right.
But I often tell my patients that undergo hip arthroscopy, they're probably my happiest group of patients if you pick the right person.
Right.
And so what the right person is someone that meets all the criteria for that doesn't have arthritis, that has impingement, that has a labrum tear, that's tried some conservative treatment. And I always joke that those people walk in and hug me at 2 weeks, whereas the shoulders are mad at me at 2 weeks. And it takes them a few months before they feel better, just because it hurts more. But the hips respond very quickly and very predictably when they're done for the right indication.
So the challenge that I find, whether that's a hip patient, a knee patient, a shoulder patient, whatever, that person that's actually in a lot of pain and gets that immediate relief from a surgical procedure can be a bit of a danger on the back end, right? Of like, they put in, 2, 3, 4 weeks of work on the rehab side, and then they're already better than they were going into surgery. Yeah. So then they're like, this is a lot better. I think I'm good. And that becomes a little bit of a danger zone for us to be like, well, objectively, you don't look great. Subjectively, I know you feel so much better, but like your motion's not back, your strength is not normal, you can't walk without a limp, all those other things. So what are those conversations like when that person that's coming in and they're hugging you 2 weeks in, they're like, Doc, you fixed me.
Yeah.
But what else is it going to take to get them where they want to go?
Well, we've all seen that, and I describe it like a roller coaster in the rehab that you feel better, and then we add more, and you go back down down the next slide. So, I think the goal is to maintain it, right? And so the key to maintaining it is building the strength and mechanics to maintain it to where it doesn't come back.
Right.
We can make your joint feel better for 4 to 6 weeks, but it's going to come back if you don't do the strengthening. Right. And that's why I always say that the rehab is as important, if not more important, than the surgery. Surgery is a very important day, but it's one day. The rehab is several months after that.
That's right.
So yeah, I think if you're not finishing the process, so to speak, then you're almost certain to have recurrent issues at some point.
That's right. Sometimes the analogy that I'll use with patients is that surgery unlocks the door, right? That was locked and we couldn't get through it. But then your goal wasn't just to step through the door. Your goal was to see this thing to completion, right?
Yeah,
so surgery was the thing that unlocked the door for us. If we didn't do that, we were never going to take the first step, right?
Yeah.
But now just taking that first step and being like, we did it. We walked in the door. It's like, no. We were wanting to walk all the way to the end of the line here to wherever we were trying to go. So I think that's really helpful. I hope that's encouraging to anybody that listens to this too. Not to say that we want to push hip surgery on everybody. In fact, I'll be completely transparent. That's often our goal from the clinical standpoint, is to keep somebody from going there when they don't have to.
Sure.
But I also think that's where a skilled surgeon and a skilled therapist comes in, is we know when to wave the white flag, so to speak, and go, hey, I don't want to waste any more of your time or energy knowing that you're actually a perfect fit for this. And if we would just do this 3-6 months from now, you're going to be so thankful that you did it. So
yeah, I think there's a misconception that surgery is a bad thing and you never want to have surgery. And certainly we don't take it lightly. It is a big life event.
It is.
But oftentimes that's the more predictable route. When you have a clearly defined pathology that's treatable, the more predictable route is to have it addressed, complete the rehab process, and move on with your life.
That's right. I think, if anything, one of the things that doing the rehab piece first is that you mentioned earlier, hip pain has a lot of other causes. So doing the rehab first can help us at least hone in or potentially address some of those other causes where, I'm going to be honest, hip rehab is not going to fix somebody's torn labrum if they have a torn labrum in most cases. But if there's a lumbar component to it, if there's a soft tissue component to their pain, we can identify those things in the rehab process early on to where now we truly can identify, is this a symptomatic labral tear or is it just they've got some other type of extra articular hip pain and they just so happen to have intra-articular pathology at the same time. That's the worst case scenario, right? Is that we operate on somebody and their pain's not gone.
Yep.
Right?
Yep.
So talk to me about that. Obviously, you try to avoid that if at all possible, but what is your response or perspective when, let's say, somebody does have that hip procedure and we know there are these other things, whether it may be their back, whether it be extra-articular things that are contributing. It doesn't mean the surgery was the wrong thing to do, but their pain's still there. Like, now what?
Yeah, I think we have to address the other causes, which it's, well, a few things. One, it's not uncommon for me to message your group or another group and say, hey, I need you to clean this stuff up before we do surgery. And by clean that stuff up, it means periotrochanteric pain syndrome, hip flexor dysfunction, low back dysfunction, all these other things that contribute to it, when there may be an intra-articular root cause, so to speak, that we're going to address surgically, but I want to address all those other things first.
Right.
If in the rehab process, which it's not uncommon to get a flare of some of those other things, then we still come back to other modalities, whether it be, dry needling, different manipulation of the spine, or different treatment modalities that you guys use. And sometimes the new frontier a little bit that I've seen a lot more is pelvic floor health. So we can have patients that we've fixed their hip, they say my hip's doing better, but I just continue to have this deep pain. And we've seen that sometimes those two go hand in hand, and pelvic floor can push those people over the hump and get them back to where they're pain-free.
I know we've had 2 or 3 folks specifically that have worked with you that it's like we feel like we've run the whole gamut and there's still this deep gluteal pain that is not resolving for whatever reason. And all of a sudden that's the last piece, the last step that nobody else thought to address because they didn't have the other symptoms that would go along with pelvic floor dysfunction, like pelvic pain or incontinence or things like that. And yet it's a next door neighbor, so it can certainly refer pain directly to that area.
Yeah, absolutely. And I think it's important to remember that most people that are impingement hips have years of altered movement patterns and hip dysfunction, which goes through the pelvis as well.
Correct.
So we've altered mechanics and maybe overloaded or unrecruited certain muscle groups, which the pelvic floor is certainly a big part of that.
Yep.
And that has to be addressed as well.
Cool. I think that's spot on. All right, we're going to transition to talking about some stuff for the knee too, because the knee is obviously something that you are also known for, and several patients that we've shared when it comes to knee rehab. So the meniscus is probably the most common injury that we see at the knee that might have a surgical indication. So let's just start there and let's talk about, from your perspective, what's some of your decision-making in terms of somebody that you would immediately recommend to have surgery for a meniscus injury versus somebody that warrants a trial of some conservative management first?
Yeah, the meniscus is a large box, right, of different, it sounds like the same injury, but it's not.
Right.
And so, the person that I would immediately recommend surgery for is a young athletic person that has a full thickness tear of their meniscus. I saw this patient this week. He's a basketball player, 20-year-old, and had an acute injury to their knee, and they have a through and through radial tear of their lateral meniscus.
Yep.
That tear, if it is not repaired, is going to cause long-term damage.
Yep.
Without a doubt. We have biomechanical studies to show us that that's essentially like not having a meniscus.
Mm-hmm.
So a radial tear, a full thickness radial tear, a root avulsion tear,
Mm-hmm.
which is also common, or a bucket handle tear would be probably the three primary indications.
You said a meniscus tear, like one of those tears, is going to cause long-term damage. Long-term damage to what?
To the whole knee, and it's going to lead to, without a doubt, it's going to lead to degenerative changes. And so probably one of the more common things I see is a meniscus root avulsion, and what the root is the ligamentous attachment at the back of the meniscus.
Right.
Good study out of the Mayo Clinic 5 to 7 years ago that showed us that if you don't have that, it's basically like having a meniscectomy biomechanically. And if you do not have that repaired, then you have a 50-50 chance of getting a total knee replacement within 5 years if you're in that pre-arthritic stage, right?
Okay.
So if you're a 45-year-old who, jumped off the curb and felt a pop in your knee, and you have a radial tear, a root avulsion, which is a radial tear of your meniscus, if that tear is untreated or if you have it debrided away, then there's a 50-50 chance you went on to a total knee arthroplasty within 5 years.
Within 5 years. Okay. Yeah, that's pretty significant. So now we know we need to operate on this individual, but we need to decide what we're going to do in the operation, and obviously different techniques within this, but the two primary categories would be some type of debridement or meniscectomy versus some type of reparative procedure. So talk to me about your thoughts and decision-making on that.
Sure. I'm a meniscus saver almost at all costs. And to that reason is I've seen so many joints that the meniscus was taken out, and then the joint space just narrows down, and that ends up to be an arthritic joint. Technology continues to evolve and advance, and I'm the beneficiary of that because of research and the natural evolution of orthopedics. But 20 years ago, they weren't repairing a lot of meniscus. And so we see a lot of patients that just had their meniscus taken out, and almost to a T, they have significant arthritis. Probably the most difficult patient for me to take care of from a meniscus standpoint is a young person that has had their meniscus resected, and they're too young for a knee replacement. So they're 24. They have minimal meniscus. They have recurrent swelling and effusions. They have joint line pain.
Yep.
That's a very difficult problem to deal with. Then you're talking about things like osteotomies and allograft meniscus transplants and things that really are salvage type procedures that don't have a long track record. Whereas if we can just preserve the meniscus day one, I think we can avoid a lot of those things. And it may not always heal, but I think we have a better chance if we try.
That's right.
So in general, I'm going to try to fix it if I can. Now, we use evidence to help us with that. So negative predictive value of that would be an older patient, tissue that's in the white zone, which gets into the basic science of the meniscus where you don't have good blood supply. And those patients are amenable to a debridement operation. And then it all depends on tear, like where the tear is, the location, does it have blood supply, does it have good tissue, and what's the patient's goals.
Yep.
So
yeah, I agree with all that. One thing I wanted to say on some of those salvage procedures too is, yes, other options do exist. Obviously, that's not a bridge you want to cross for a number of reasons if you don't have to. One is that the success rate of those procedures is much less predictable than just a traditional meniscus repair. And then also the downtime from those procedures is significant too. So the combination of hoping that a salvage procedure works, having to spend a lot of downtime hoping that it works, and then the higher likelihood that one of those procedures still doesn't quite get you where you want to go in terms of pain relief. It's time, money, energy, all that gets lost in the process. So I'm agreeing with your sentiment of preserving the meniscus at all costs.
And I think the challenge with that on the front end, and this is what we run into a lot, is that it's actually a quicker recovery to have it taken out.
Correct.
Right? To have it debrided, and you may go see one doctor and he tells you, yeah, we'll have you back out there in 4 weeks, and we tell you, I'm sorry, your season's over. But the reason we tell you that we may tell you that your season's over is because we're looking at the long-term health of your knee over the next 10 to 15 years.
That's right.
And so it's unfortunately a longer recovery if we do a repair because we're waiting on biology to heal that meniscus. But the benefits far outweigh the downside.
That's right.
So.
A classic example for those that follow contemporary, like professional sports. So J.J. McCarthy last year, quarterback for the Vikings, tore his meniscus in a preseason game.
Yep.
And obviously underwent a reparative procedure that cost him the entire season. The NFL season is 18 weeks plus their team went to the playoffs, so more like 20 weeks. Whereas had they done a meniscectomy, and you've seen it, it happens in the NFL, there's guys that have a meniscectomy on their team's bye week and they don't even miss a game.
Correct.
So there are obviously decisions that have to be made, right? In terms of what are this person's priorities? You know, if that injury happened the week before the Super Bowl, there might have been a different decision made,
Right.
you know? And that's not to say the person made the right or wrong decision. I think they certainly made the right decision for somebody who hasn't played a snap of NFL football. And yet I think people were surprised when they hear torn meniscus out for the season.
Yeah.
I hear torn meniscus from this guy who's a defensive tackle who he's out there in 2 weeks.
Yeah. Yeah. I think that's a great case to discuss, because that was a career decision, right? They made the decision. He's our franchise quarterback. We want him for the next 10 to 15 years, not this first season.
Right.
And it was refreshing to see, to extrapolate that to the common man who's around here who, you know, works at BMW, and they had a coworker who was out of work for 4 weeks after they had their meniscus trimmed, and we're telling them they're going to be out for 3 months after they had their meniscus repaired.
Right.
They're not all created equal, and each patient has to have a tailored approach specific to their pathology.
Yep.
And the long-term health of their knee. To that point, 2 patients may have the exact same tear, and one patient already has arthritis, and we say, hey, look, you're going to put a huge investment into recovering from this from a repair with probably not that much benefit because you're well on your way to a total knee replacement anyway.
Sure.
That may be someone that we debride, as opposed to someone who may be in the same age group and have the same tear, but they don't have the arthritic changes.
Mm-hmm.
And we may say, we're hoping to prolong the life of your knee and delay that arthritis and knee replacement progression.
Yeah.
So.
So from a therapist perspective, there are some procedures and some types of patient where we see relative uniformity across the industry of surgeons as far as what their expectations are and what their protocols are and things like that. I would say meniscus repair is one of those places where we see a little bit less uniformity, where there's some differing opinions out there about how early can somebody bear weight, how early can they start to bend their knee, how early can they come out of a brace, all those kind of things. You're certainly not reckless, but I do find that you're somebody that's a little more open in the right cases to have somebody start putting a little more weight through it, start doing some non-weight bearing flexion past a certain degree and things like that. Talk to me about just your thought process behind that and where you fall on, obviously we're trying to protect this tissue, but also there is a role of weight bearing and motion that helps the reparative process as well. So
Yeah,
talk through
sure.
that.
Yeah, I think it goes back to my just patient treatment philosophy, which is every patient is different and every patient deserves an individual approach, right? You know, it's not a hammer and everything's a nail. So to the point we discussed that all meniscus tears are different. You may have one meniscus tear that's small and we put a couple little stitches across it and it feels great and it's really good tissue. I don't think we have to immobilize that person for a prolonged period of time and keep their weight off of it. There's been some studies to show that we don't have to do that, and it has done really well. From your side of the world, if I tell you this person can't put weight on their leg for 6 weeks and they can't range their knee the whole way for 6 weeks, you can throw everything at it that you have it, but they're going to have significant atrophy and dysfunction, and then those parameters on the front end do not add up to a return in the timely fashion that a lot of people want. Right. So if you sit there and do nothing for 6 weeks, you're not going to be recovered in 4 months. It's not going to happen.
Right.
Whereas if we can start some gradual weight bearing and range of motion in the early, first 4 to 6 weeks, then I think we can accelerate that rehab.
Absolutely.
So that's a very individual basis for me. After I do every surgery, I make an individual plan for that. We have protocols that we kind of fall into, but we still tailor every specific tear to what we think is how fast we can go.
Yep.
And then we communicate that to the physical therapist, who then executes that plan and then can work within that range. I think that's been one of the biggest things that we've progressed in the past 10 years. Even
Agreed.
when I was training, it was every patient with a meniscus repair was on crutches and in a brace for 6 weeks. And it took forever to recover. And we still do that certain times. There are still certain tears that we have to do that because the tear is so severe.
Right.
I think any amount of load that we can put through that helps you guys get going quicker.
Of course. The one, just to chime in from a therapist perspective, whether it's ACL, meniscus, whatever, extension is the motion that we worry about the most initially. And extension is something that if we do the right things, typically in the right dose, within 2 to 4 weeks, extension is going to come back 99% of the time if we do the right things. Flexion becomes a challenge when weight bearing is limited. Like flexion is one of those things that it actually comes back from weight bearing activity. When I can actually get somebody into a squatting position or get somebody on a leg press where I can actually load them into some flexion, the flexion tends to take care of itself. And so that is a challenge from a rehab standpoint. Obviously, we want to respect tissue healing first and foremost, but I do find the longer that we limit motion and limit weight bearing at the same time, the harder it is for that flexion to come back. So that's that person that is now 12 weeks out and their flexion is still 120 degrees. And it's a frustrating process.
And everything else is on hold until you get it.
Correct. Yeah. Right. And it's just, so yes, we wanted the tissue to heal. However, at the same time, I find very rarely do we endanger somebody when we're doing some type of non-weight bearing flexion, but there's just only so much we can get from that, right? Yeah. Like at some point, we do have to be able to load that person into some flexion, and that's how they get those last 10 or 20 degrees of flexion. And so that's why a therapist, in my perspective, appreciates a surgeon that's open to that conversation and is not always so rigidly protocol driven to say, hey, everything else looks great about this person. What did you see while you were in there? Because if we need to wait 6 weeks, we wait 6 weeks. But is there anything we can do to start this person bending a little more sooner? That conversation is a good one to have.
Yeah, those are tough decisions. And I think that gets back to it has to be a shared decision-making and relationship between the therapist and the doctor. And you know, to put a plug, I guess, for you guys, but it needs to be someone that is familiar with doing that in that patient population.
Correct.
So that you have the experience to understand, okay, this is okay to progress and push on. This is not. These
Correct.
are warning signs we need to stop.
Yep.
It's very hard as a physician who sees a patient every 4 weeks to say, you can absolutely do this or you can absolutely not do this. Because a lot changes. You guys spend hours with them a week and we see them for 10 minutes.
That's right. So I just wanted to follow up on something that you said from a rehab standpoint, which is talking about this idea of the therapist needs to know when, what, and how to push and when not to. So I'll just share the way that we phrase that. We actually educate patients on this, and obviously we talk to our therapists about this as well. So where this comes from is I use a traffic light analogy. There's red lights, yellow lights, and green lights, right? Green light means we're good to go. Yellow light means we need to proceed with a lot of caution here, and red light is we got to stop. And amongst that, we have 3 factors that we are considering as to whether this patient today is a green light, yellow light, or a red light. So there's 3 S words: sore, stiff, and swollen. Okay. So the 3 S words, if they all happen together at the same time, that is a red light. Okay. If somebody is sore, meaning that they are in significant discomfort at rest, not it hurts when I go downstairs or it hurts when I pivot and turn a certain way. I'm talking like I'm just sitting here right now and my knee is aching. I'm hurting. If they're swollen, that's pretty self-explanatory, right? We take girth measurements when we see patients. And so if we're noticing that there is an increase in circumference or girth about the joint to where they actually have some type of joint effusion, that is certainly of concern. That indicates an angry, inflamed joint. And then the stiff piece, we're measuring motion as we go along, and it is not acceptable for somebody to lose motion between times that we've seen them. That is another red flag to say this joint is not happy and we need to pump the brakes a little bit. So what often happens is that somebody is some combination of 1 or 2 of those things. Rarely are they all 3. In that case, that's kind of usually you'll get a call from us if that's the case, right? But typically it's, I'm sore, right? Like my knee has just ached the last couple of weeks, or, I noticed it was a little swollen after the last time we session, or, hey, I could easily bend to 90 degrees and all of a sudden it's 75 and it's stiff. That's our yellow light. When we have one of those, it's just a yellow light. It's a proceed with caution. And all that means is we need to work whatever that thing is out before we just add load or add new things, right? Yep. So just to summarize that process, if somebody has none of those, they're not sore, stiff, or swollen, we're going to progress them as we can per whatever protocol or guidelines that we've been given. There's no reason to not continue to progress that person. Then if that person has 1 or 2 of those things, that's the yellow light of we need to address that thing, that stiffness, that soreness, or that swelling before we proceed. And then if that person has all 3 of those, that's the angry, irritated, in some cases injured joint that needs to be respected. That can't just be the communication of, hey, you know what, soreness, stiffness, and swelling, that's just part of the rehab process. We're just gonna have to grit through this. So I know it hurts. I know you don't want to put full weight on this leg right now, but I just need you to do it. That's not okay. So I just wanted to kind of summarize that. And I'm sure you probably give similar education to some of your clients, but from our perspective, that's the way that we message that. We say, it's not uncommon to experience any of these 3 things in isolation, right? You are going to have days where your knee feels sore. You're going to have days where you wake up and it's a little stiff. You might even have days where we've increased activity and all of a sudden it's a little bit swollen. That's not okay for all 3 of those things to happen at the same time.
Yeah, I like that. That's a good system.
Okay, so we were talking about meniscus. So we mentioned surgical, do we do surgery or not? And then we talked about the people that do get surgery, what technique do they do? And then we talked about some of the rehab considerations on that. But just because you have a meniscus tear doesn't mean you need to have surgery. So there's plenty of evidence to say, in fact, that surgery can lead to inferior outcomes for people that have certain joint characteristics or certain patient demographics versus the person that is managed conservatively. So talk to me about your perspective on that. Who are the people that you would honestly shy away from surgery on given certain presentation?
Yeah, I often joke with my staff that I spend more time talking people out of meniscus surgery than into meniscus surgery, because we have pretty good studies to show us there's a lot of us walking around the community that have some component of a meniscus tear on MRI.
Right.
The question is, does that correlate with your symptoms? Do you have meniscus-based pain?
Right.
Do you have joint line pain? And do you have arthritis? Because almost everyone that has substantial arthritis also has a meniscus tear.
Right.
Me putting a camera in your knee and cleaning out the meniscus will not address the arthritis pain if the problem is from the bone and the cartilage.
Right.
And that's difficult to understand at times because the report says there's a tear and our brain thinks there's a tear, let's fix it. So yeah, that arthritic joints in general do not do well from a meniscus surgery and from a scope.
Right.
I do think there is a small subset of patients that have arthritis and then they have a mechanical type meniscus symptoms that gives them swelling and pain and catching and clicking, or they may have, it's often golfers or tennis players, pickleball players, where when they rotate that they get a click or a sharp pain. Right. And I do think we can help those people at time with the meniscus surgery. But just because you have a meniscus tear by no means means that you always need surgery.
Right. And in fact, I can think of 2 patients that we've seen in our office in the last 2 weeks that have responded extremely well initially. Now, one did need an injection to kind of get them over the hump from a pain standpoint, but they've done very well otherwise. And then the other, honestly, it's just like, hey, you had a really stiff knee. You lacked 10 degrees of extension. Right. You were bearing weight on a part of your joint that shouldn't be bearing that kind of weight when you walk. And so all of a sudden we just redistribute force and you happen to feel a lot better.
Well, that's the other thing I've learned in my practice over the past 10 years is that you may have an inciting event, and that may be the meniscus in an older population. This discussion is more an older population. A young athletic person that has an acute injury, that's a different discussion, and that's usually a recommendation is going to be to treat the pathology. But in an older population, you may have had pre-existing meniscus or arthritis conditions. You have an inciting event to your knee.
Yep.
And then the function of your knee completely changes. Your quad shuts down, you become hamstring dominant, your hamstrings are weak, starts referring pain.
Yep.
The femoral tracking gets off, and you're limping around with a flexed knee, and of course it hurts. So if you can restore all of those other variables, you may be just fine with having a small little meniscus tear.
That's right. Yep. And then the conversation that we have with somebody again is, yes, your pain got better because we did these other things. Your meniscus tear may or may not ever look any better on MRI. In fact, chances are it's not. But does somebody care if they've restored function, they've not burned any bridges in terms of taking out tissue from their knee that they can't get back? And meanwhile, if by some chance 3, 4, 10 years from now that meniscus tear becomes symptomatic again, then we can revisit that conversation. Sure. But there's no need to burn that bridge right now.
I actually saw that patient this week. She had an MRI from 2021. She had a small horizontal posterior horn medial meniscus tear. Elected to do non-operative treatment at the time. Did very well. Has done very well. Started having recurrent symptoms this year. Recurrent effusions. Has some mechanical symptoms. Repeat MRI. The tear's gotten worse. She now has a displaced flap. And now we're going to do a meniscectomy on her because she has recurrent effusions, pain with rotation, mechanical symptoms.
But that doesn't mean that you think she should have had surgery 4 years ago.
No, I would have done what she did.
Exactly.
Yeah. And she got 4 years out of it.
Exactly.
But at this point, I think it's unlikely. And we had that discussion. You can try the therapy again. But she's like, I'm just tired of dealing with it. Let's go ahead and address it.
Right. So ACL injuries are something that unfortunately we still see a lot of, particularly in our middle, high school, and collegiate athletes in this community. And so we're fortunate to be able to care for a lot of those individuals. But unfortunately, it is a challenging process, both from rehab and from surgery. So I want to take an opportunity to talk about that. The first thing I wanted to ask on ACL injury is just what are some of the expectations overall that you give athletes, parents, coaches, things like that? What's the kind of let's assume that we've decided that we need to operate on this person. What's the pre-surgery talk in terms of what the next month, 6 months, year plus is going to look like for them?
Yeah, the first thing I tell them is this is the worst part of my job. To sit across from you, and there's often a lot of emotion, rightfully so. A lot of these athletes have a lot invested to get to where they are, and then this unfortunately wrecks that plan for a while.
Yep.
So the worst part of my job is, I'm sorry, you tore your ACL. You're not going to play your sport this season.
Right.
Or you're, a mom that snow skied with her children, and you've got a long road ahead of you, right?
Yep.
We're seeing that more and more, that it's not just the young athlete. With the active population in Greenville, especially, we have a lot of people in their 30s and 40s that are athletes, that are and we see a lot more ACL tears in that population than we used to. So yeah, the first is, this stinks, and I usually tell them, hey, process that. Don't try to hide from that. Mental health is real, and you've got to process that, deal with it, and then go forward. And you have to decide, okay, now this is the challenge I've been given, this is the hand I've been dealt, and this is what I'm going to attack. A part of that is surgery. Okay, what I normally tell them is that the bad news is all of that, right? For your ACL, it's a big thing. It's going to take you a while. The good news is this is something we've gotten pretty good at, because we have a lot of practice and we have a lot of research over the years. And so there's no reason that you can't make a full return to everything you want to do,
Right.
And live a very normal lifestyle for many, many years, as long as you have a good surgery and good therapy, and that you buy in and put in a lot of hard work.
Yeah. Awesome.
And then I also tell them, you get out what you put in.
100%.
And then back to the, from injury to that, we don't want to do surgery until, my normal baseline is, we don't want to do surgery till that knee looks like the other knee. Now, there are some exceptions where certain injuries make us go quicker, but usually we want to restore motion, restore quad function, certainly restore extension for sure, and some quad function, so that we can recover from that quickly.
Yeah.
If you go in with a stiff knee, you're coming out with a stiff knee.
That absolutely true. And then there's obviously some things that we can do from a post-surgical standpoint to prevent that too. We'll talk about that in a second. I wanted to ask you, I'm going to save that question, actually. The other question I was going to ask you is, so there's a lot of choices that somebody can make. They know they've torn their ACL, they've gotten their MRI, and now they have choices, right? They have choices about which surgeon to use, where they're going to do their rehab, what type of graft, all these other things. So let's start with the surgeon piece. Granted, you are a surgeon, but understand that not every orthopedic surgeon is an expert at ACL reconstruction. That's just a fact, right? So maybe just talk to the idea that, I understand you're not the only person in the area that knows how to do a good ACL reconstruction, but at the same time, what is the value of actually doing your research and understanding that you're working with somebody that is on the cutting edge of what's available versus somebody that does 4 or 5 of these a year?
Sure, yeah. What I always tell the patients is, I don't do knee replacements, I don't do spine surgery.
Right.
And if you needed that, I'd send you to somebody else. And so an ACL surgery can be very predictable and very successful, but it also can go really wrong.
Right.
And so you need someone that's experienced in doing that. I'm not the only person in the city that is that person, but you need someone that is experienced doing it, and that is used to caring for patients that are similar to you and your, performance, age, activity, goals, all the above. And you need someone that, for lack of a better term, knows how to get out of trouble, right? So there's a lot of ways. There's a lot of nuances to that surgery, and you don't want somebody that just does it a few times, because there's sometimes you have to pivot and try something different. And then I don't think you want somebody that does the exact same thing every time, to be quite honest with you. I think that every patient's different and needs a unique approach.
Right.
And so you have to tailor that approach.
Right. I'm obviously not in the operating room 99.9% of the time when somebody has an ACL reconstruction. But if I'm seeing somebody, I would say, be quite honest, from a therapist perspective, within the first day or two, I could almost, you could blind me to who their surgeon was, and I could still tell some different features of how this person presents. I'd say there's two. One is a dead giveaway, which is just essentially, what do they look like when they come to me? Like, legitimately, what are they wearing? Unfortunately, there are still some folks out there that have some pretty barbaric ways of immobilizing the knee after an ACL reconstruction, which is very unfortunate. But then the other piece is truly a swelling / I'm just going to call trauma to the knee situation. I do find that there have been some instances where we just see that even though a reparative procedure had to be done, where, sorry, if you've never YouTubed this or known this, like, as a part of the ACL reconstruction, there's tunnels drilled in bone, there's tissue harvested from other places in the knee. So it's not a pretty procedure. However, you can tell when a knee has been really traumatized from all these extra releases and debriding procedures that can be insulting to the knee. And unfortunately, that's the person that 2, 3, 4 weeks in, we're fighting hard on scar formation and kind of sticky anterior intervals and things like that. So from a therapist perspective, that's why we recommend folks like Dr. Scott Watson and a few others that we trust in the area from a standpoint of, because we know predictably what the knee is going to look like when it comes into, and they're going to do exactly what your knee needs, but it's not going to be any more, if that makes sense.
Yeah,
right?
sure.
Unfortunately, we do see that from time to time where it's just like, this looks like this is a breeding ground for scar tissue.
Yeah.
I don't know how else to say that.
Yeah, surgery is not a benign thing, right? I mean, it's a major event. And so
Right.
we have to be aware of that as we operate on these knees.
That's right. So we don't need to turn this into an ACL education session on all the different graft types and things like that. But I just want to ask you a personal question. If you were to tear your ACL tomorrow and you come to the decision that you're going to have an ACL reconstruction, you don't have to tell me who, but what? What procedure would you have done? What would that look like for you, knowing your unique patient factors?
Yeah, well, unfortunately, I'm older and less athletic than I used to be. I'm in my 40s, getting into my mid 40s, but I would have surgery, and people say, well, I don't really do that much stuff anymore, but I think it preserves the long-term health of the knee.
Right.
God made us with an ACL for a reason. To think we can just live 25 years without one, I think is unlikely. Now, if I was 60, that's a different conversation. Or if I already had arthritis, that's a different conversation. So I would have surgery because you want to stay active and you want to, even just activities of daily living, not having an ACL can give you instability. And at this point in my life, I'm probably entering where I would consider having an allograft,
That's fair.
which is rare for me to recommend, but because of a few factors. One, the results in people in their 40s are pretty similar, and then the hit on your life is a little less. And so getting back to being dad and doctor and husband would be of importance of doing that quickly. If I was not, I would have a hard conversation of allograft versus if I was going to have an autograft procedure, I'd have a quad tendon autograft.
Okay.
And I would have a hard decision between those two at this point in my life. 5 years ago, 10 years ago, I would have told you quad tendon autograft for sure.
Okay.
If I was in my 30s and still playing a lot of sports and doing things like
that.
For sure.
So it's interesting that you say that, because we get asked that question, of course, by patients that are considering the process and the procedure. And myself, I actually tell people a similar thing of, I personally would choose, I would consider an allograft. And one of the reasons why is that some of the studies that look at the failure rates of allograft, which unfortunately have been shown to be higher in some cases, if you look at the rehab that was done on those folks, is like an average of like 12.4 weeks, stuff like that. And it's like, well, maybe it wasn't the graft that failed. Maybe it was the fact that they felt so much better. 2 weeks, 4 weeks, 6 weeks, 8 weeks after surgery. By the time they got to 12 weeks, like, I think I'm good.
Yeah.
And the respect for the biology of that was not nearly what the respect for a graft that needs to be completely revascularized was. You know what I'm saying?
Yeah,
like
for sure.
this graft, it still needs to serve the same function as that harvested graft from your quad, from your patellar tendon, from your hamstring, from wherever else. But because they feel so much better, I think this has been my personal experience in the few cases of it that I've seen, but also just looking at the numbers, I think there's a high self-discharge rate from PT because it's like, I think I'm good.
Well, ACL literature is so hard to interpret, right? Because number one, we know allografts do not do well in people under the age of 30.
Right.
And really, it's rare for me to recommend an allograft in someone in their 30s unless they're, depending on their specific goals.
Right.
And then, but we have now evidence to show us that it takes a lot longer for that, to what you were just alluding to, for that allograft to incorporate. It's someone else's tissue.
Correct.
It takes a lot longer for that to incorporate than it does your tissue.
Right.
That's a major concern for someone that has, hey, I want to do this triathlon in 10 months, or I want to return to this volleyball league or soccer league in this amount of. For someone that doesn't have a timetable, it's fine to give it 12, 16 months to mature, like me.
That's right.
But I think that is a consideration for sure.
So this is a perfect segue to the next conversation I was going to ask. So we talked about selecting a surgeon, what good surgery looks like. Let's talk about the rehab side of things for a second. What in your mind and in your experience, kind of compare and contrast what good ACL rehab looks like versus what not so good ACL rehab looks like?
Yeah, I think it starts day 1, 2, or 3. You got to get the patellar moving, and you got to have patellar mobilization, get the patella moving, and you got to get extension quickly, and you got to get that quad to fire. I always tell the patients when they come back, you got, for their first post-op appointment, you got your first 4 goals are get the swelling out, get it straight, get your kneecap moving, and get your quad to fire. And it starts with that. In general, I would say what good ACL rehab looks like is someone that's experienced doing it and understands the phases, right? Like those are the phases, those are the goals at the beginning, but then there's a whole bunch of things right behind that we have to get, right? And then understanding the timeline. This is not something you can rush through. We as a orthopedic and physical therapy community have learned that the hard way over the last 25 years.
Yep.
This is not something you can shrink. You cannot shrink it from 9 months to 4 months and do well. You may get lucky, but the studies would show that the earlier you try to go back, the higher likelihood that this is not going to go well.
Right.
And so you need, from my standpoint, a good physical therapist for ACL, and you guys, Limitless is certainly one of those groups. There's other groups in town that do that well. There are other specific therapists that do that well as well, but it's understanding why we're doing certain things and understanding when to do those things, and then being on board with the same end result and return criteria and timeline.
Yep. So for me, I agree with everything you said. For me, good ACL rehab blends 3 different factors. So the first one you talked about was timeline. The biology piece of this is just inevitable. It's something that we can't speed up. We still have to respect the timelines. And then we still have to blend that with subjective and objective markers that we need to hit.
Yes.
Right. And so we cannot base our decisions just off of 1 or 2 of those. All 3 of those have to be factored into every decision that we make of, is this person ready to get off crutches? Is this person ready to run? Is this person ready to pivot and cut again? Is this person ready to return to their sports practice, competition, contact, all those things? Yes, you're right. There is good documentation about timelines, 9 months being a common number that gets thrown out around nowadays of being the kind of threshold for when we should return to sport. But just because somebody's 9 months post-op doesn't mean they're ready either.
Yeah, 100%.
Right?
Yeah.
Like, we still have some subjective and objective markers, both from a balance, strength, gait, power, endurance, all these other things that those numbers have been tried and true as well in the literature to say, hey, when we don't meet these numbers, someone's risk of injury on the other side or re-injury is significantly higher. Yep. And so we have to be good caretakers of all 3 of those things. I think that's what good ACL rehab looks like. And then the other piece is actually letting people know what the goal is, because we have to set short, small goals for people, because unfortunately it's a gruesome process to think that all I'm working towards for the next 9 months is being able to put the pads on again, or is being able to put the cleats on again, or is being able to get back on the basketball court or the pickleball court or whatever that thing may be. So good rehab to me looks like, you said, understanding the phases and being able to set those short-term goals, being able to dangle the carrot to keep somebody engaged, because something you said at the very beginning of this ACL conversation was you get out what you put into it. I'll agree with that and just tag on this. The term I'll use is ownership, right? We have to get them to take ownership of the process. And sometimes ownership of the process is not ownership of the end goal. It's ownership of what can we control in the next 3 or 4 weeks?
Yep.
What can we accomplish? Our goal over the next 3 or 4 weeks is just to unlock that brace, or to get you off crutches, or to get you back driving again, or going up and down stairs, or whatever it is. All those other goals, they'll take care of themselves, but we can't do any of that before we do this.
Yeah,
so
100%. I love that. Yeah. Yeah, that's often what I tell the patients too, is you got to break it into boxes, right? Break it into 4-week periods.
Yep.
And you often get these really motivated people that are ready to get back and say, hey, we'll put you in a box. You can dominate that box.
Yep.
Just don't go outside that box.
That's right. That's exactly right.
And then, 2 things you said, which I love, is engage. I think that's one of the biggest jobs of the physical therapist, is to keep that athlete engaged.
Yep.
So that they don't just get monotonous and bored.
Yep.
And then the other thing is objective. Like I basically at this point will not send a patient to rehab an ACL to a therapist that doesn't use objective data.
Right.
In all those phases, but certainly at the end, it's not just, well, it's been 6 months or even 9 months is our number now. It's 9 months, you're good to go. And I always tell the patients that it's not a calendar decision. It's how's your knee look? How does your data look? How's the strength look? How's your function look? All those things.
Right on.
We've cleared people at 8. We've taken till 14 before. It just depends on how you're doing.
Absolutely. Well, you just kind of jumped right into another question that I had was, I think, right or wrong, there are some surgeons that just think kind of all rehab and all therapists are created the same. And so it's, hey, I did this surgery, whoever's available, you take it. And I know there's some other surgeons that kind of have some people that they specifically trust, whether it's with an ACL, with a hip scope, with any of these procedures that we talk about. So talk to me about where you fall on that. And in your mind, how do you identify somebody that you feel comfortable saying, hey, this is somebody that's going to take good care of my patient, that we're going to be on the same page about how the rehab process is going to work. Take us kind of inside your mind when you're making that recommendation to a patient.
Yeah, I think trust is earned and gained over time, right? And I'm not against new people earning that trust and giving me a chance, but for me, it's got to be someone that, number one, has taken an interest in it,
Right.
and shows that they've taken an interest in it, and that cares to read and to have experience and to learn and to do what we're doing right now, to
Right.
take your free time to talk about something.
That's
you know
it.
what I mean?
Come on.
And has a general passion for doing it, and cares for the patient.
Yep.
Because that is a patient. That's someone's, mom, daughter, sister, and it's very important to them. And then, that will communicate with me, and we're a team approach. Because like I said earlier, physical therapists can make me look really bad, or they can make me look really good sometimes.
Correct.
And so yeah, for me that's that. And then I think a subspecialist approach. I often say that Greenville's a big enough town now where you deserve somebody that this is their expertise. It is not a small town where you just have to go to one option down the street.
That's right.
There's options, and so go get. I'm not the best option for you if you have, a herniated disc in your back necessarily, right? Yeah. And there's things like that in your world that you probably aren't the best option for either. But for something like an ACL injury, go to someone that they're experienced in it, they care about it, they're evolving and continuing to learn, and they're aware of the appropriate objective criteria that we need to use in 2025, and they're aware of return to sport guidelines and times, and what phases are.
Absolutely. Let's talk about one of the other factors that we talked about. People get to choose. We say they get to pick their surgeon. We say they get to pick their rehab. Graft is another one of those things that they get to pick, and maybe not pick as in ordered off a menu, but that's one of the conversations that's happening alongside a surgeon, right? And a surgeon usually has at least one or two techniques that they are most confident in and that they specifically believe in. And so I wanted to ask you, from your perspective, obviously it's a decision you get to make for each patient, but where do you tend to lean when it comes to graft choices?
Yeah, I think the first thing is it's an individual approach, right? And to what you said, they do get to choose. And so oftentimes, these are long appointments for me when we have this conversation, and I'll lay out a bunch of the options and encourage them to do their own research. The bottom line is there are pros and cons to whatever we use, right? We are, for lack of a better term, robbing Peter to pay Paul to do an ACL reconstruction. And so we got to take a piece of, we either have to use, I always say there's two broad categories: allograft tissue, which is cadaver tissue, or your tissue. And most people, I'm going to recommend your tissue, but there's a population for allograft. And then I list out the pros and cons of there's three main options for autograft tissue: quad tendon, patellar tendon, or BTB, bone tendon bone graft that people often say, or hamstring tendon. And we'll list the pros and cons of all of those. And that's, we're getting in the weeds there with talking about all those details. And there's, the number one thing is I think that the surgeon needs to do it well. And you need to have an adequate, good piece of tissue to do that with, and put the tunnels in the right spot. But we have seen, as the evidence grows, that it looks like quad tendon and patellar tendon are doing better historically over the last 10 years than hamstring tendons are. And those are big, massive studies out of Europe and even in the U.S. now of recurrence rate and revision rates. And so I'll usually, in a young athletic person, have a conversation of, hey, my recommendation is quad tendon or patellar tendon. These are the pros and cons of each of these, and that gets really nuanced. There's pros and cons of each of those. I've had very good results with both of those grafts, and I, depending on the patient, I think one may be better than the other, but I think they both have stood up well to the test of time, and they have similar results in the big studies.
Yeah. So you were kind of weighing the BTB or the patellar tendon graft alongside the quad tendon graft there. But when I asked you earlier about what you would do, you said potentially an allograft, or if you were to do an autograft, it would be a quad tendon. So why for you would you choose quad tendon over patellar tendon?
Good question. Yeah. And I think the recovery on the front end's a little bit easier from quad tendon. The advantage of a BTB is that we do get bone. That's where the B comes from.
Right.
What we like about that B is the bone is that it heals well. It heals quickly. Bone heals to bone quickly, and it's rigid. The downside is we do have to cut your bone, and that makes it a little tougher on the front end. Whereas the quad tendon graft that I use is an all soft tissue graft, and the results of that are really good long term, and it incorporates very well by the 9-month time period. But I think the first month is probably a little bit easier.
Correct. Yeah.
If
And
my
then,
daughter tore it and she was a high school soccer player, that'd probably be a different discussion.
right. The other issue that, I mean, there's, like you said, there's pros and cons to each. The other issue that we run into with the BTB, particularly for somebody that thinks they're going to spend any amount of time kneeling, is that can become a
Correct.
like for your lifetime uncomfortable thing sometimes. Of
Yes.
just, that is just a more sensitive area forever. And so just a conversation for somebody whose activities, sports, interests, whatever involve any kind of crawling, kneeling, getting on and off the ground, the BTB is just a consideration to say, hey, you're going to have an incision right over that weight-bearing part of your knee when you're kneeling,
Yep.
and that's not the most
And
comfortable
we
thing in
talk
the
to
world.
every patient about that. Even if they're a high school or college age kid of, hey, do you have plans to do a job where you're going to work on your knees
Right.
or climb a lot or
Yep.
something like that? Because that has been shown in the big studies to be more prevalent
Right.
in BTB grafts.
But guess what? That's not an ACL specific situation either, because guess what? The people that are getting their knees replaced are getting an incision in that same area.
Yep.
I remember a story with my mom where she did great from her. She had her surgery done in November, so we were like 6 weeks out from Christmas, and she was feeling really good until she decided to kneel down and check the water under the Christmas tree for the first time, and then put pressure on her knee. And she said, "Okay, I don't know if I'm ever going to do that again." So
Yep.
that is a unique presentation on that one. Okay, so wanted to ask another question about ACL then. So we have the option of obviously not doing surgery, which we talked about the consequences of that decision sometimes. We talked about a reconstructive surgery, which means we can't tie the loose ends together. We've got to make a new ligament, right? But there are reparative options out there for either just high-grade partial injuries or potentially a full injury if that's possible. So why don't you just bring people up to speed on the possibilities that are out there right now for a
Yes.
reparative procedure
So I'd
instead?
say from a surgical perspective, 90%, maybe 90+% are going to be a reconstruction operation, which means
Right.
we take another piece of tissue, we drill some holes and make a new graft.
Right.
And that's the 9-month recovery that we're talking about
Right.
on a round number. We have started doing ACL repairs again in the past 5 years. And the reason I say again is historically that got a bad rap when it was done 20 plus years ago.
Yep.
I think that was mostly because we didn't have the technology to do what we needed to do. With the advent of technology and what's called the internal brace, which is basically a heavy piece of tape suture that protects the ACL, we have gone back to repairing some of these ACLs when it's what we call an avulsion, where it's torn just off the bone. So picture 80-90% of the ligament looks good. It just pulls right off.
Yep.
You hate to take all that out and throw it away.
Right.
And so to me, I've had really good results with that there are some good evidence coming out now that 2-year and 5-year outcomes are very similar when you pick the right patient.
Right.
To me, that's a unique patient population. The ideal candidate for that would probably be someone in their 30s who's a little bit lower demand, still athletic, and wants to go back to being athletic and being active, but we can preserve their tissue. The advantages of that seems to be the body seems to handle it a little bit better and a little bit faster, and the biology speeds up a little bit.
Right.
And so it's hard to get nailed down to a timeline, but we certainly have had several patients that becomes more of a 5 to 7 month process as opposed to a 9 to 12 month process.
But you mentioned too that person is typically not returning to a collision sport or something like that.
It is
relative to
it is being done sometimes in
Right.
that patient population. In my practice, that is a rare indication. I have
Sure.
certainly done that in a couple unique cases.
Sure.
I think that's more complicated and somewhat.
Fair enough.
And to be perfectly honest with you, I have a hard time looking at someone and saying, you're going to miss this year and I'm going to do this surgery. And there's a chance if it doesn't work, you also have to miss next year. You know what I mean?
Right.
And so I think, and in the studies that we have, the failure rates of ACL repair are higher in the younger competitive athlete population. So 21 and under that's playing competitive sports, the failure rate's higher. Whereas people that are 30 and above, the results look really good so
Yeah,
far.
absolutely. Well, I thought of one more ACL question, then we'll make this our last one. So somebody's cleared to return to sport. I just want to hear your perspective on bracing versus not bracing, and obviously the implications that go with that. We obviously get that question a lot because parents want to know, do they need one? Athletes almost always hate them.
Yep.
And so just, talk to me
Yeah,
about
it's a
that.
difficult discussion that I feel like I have 3 times a week, especially this time of year as we're
Right.
going back to football and soccer,
Right.
and a lot of people that tore last year. The short of it is I cannot give you a study that shows you that wearing a brace is going to prevent you from re-tearing your ACL. There's a study about an MCL that it may prevent some MCL injuries. In general, we feel like it gives the athletes some more confidence when they first get back. I think this is a tailored individual approach. It depends on their progression, how they look in rehab, their timeline, where someone that just hit 9 months as their sport starts compared to someone's at more like 11 or 12 months.
Right.
And in general, I think it provides confidence. Their sport, an offensive tackle, much more amenable to a brace compared to a center back in soccer. Right. And so, and oftentimes the speed athletes hate them. Right. In general, what I'll say is let's start with one and let's try to get as used to it as we can. And then as we get further along, we develop more confidence and more stability and more fluid movement patterns. We can have a conversation about transitioning out of it.
Yeah. Well, Dr. Watson, I want to say thank you. Thank you for taking some time. Thank you for giving us your wisdom, and thanks for sharing that with our audience. We're excited to get that out there to them. Let people know just like where you are and where people can find you if they're interested in scheduling an appointment with you, learning more about you, anything like that.
Yeah, I appreciate the opportunity to be here. Enjoy the conversation. As always, appreciate you guys taking care of our patients. So I'm at Bon Secours Piedmont Orthopedics, and we have a website, obviously, that you can find, and an office number that you can call.
All right, cool. I think that wraps it up for today. I appreciate it.
Yeah, thanks.